the bleeding risk? With the placebo alone ticagrelol, 4.5% may have bleeding risk if they fall in 3 to 5 bleeding risk criteria. And 1.1% to 3% if it is low bleeding risk, 12-month randomization. So ticagrelol alone is good enough if you have even a complex PCI, which is very good for all of us. And we can, even I tried in my clinical practice, and I agree with this finding of Twilight trial. Now, based on the type of drugs used on drug-eluting stent, everolimus or zotariolimus, zotariolimus, or biolimus. And this has shown that the Mackie at 18 months using various forms, and it's shown that the ticagrelol along with aspirin is better DAPT than ticagrelol with clopidogrel. So current guidelines recommend that prolonged DAPT in ACS is very important. Otherwise, if you stop prolonged DAPT of 1 year in ACS, you will have recurrent MI, and you need to use ticagrelol. Clopidogrel and prasugrel also reduces MI, but more potent with ticagrelol. Almost ticagrelol and prasugrel results are almost identical. So no doubt meta-analysis study has been done, and it has shown that aggregated results showed that no increase in major bleeding risk using ticagrelol, and ticagrelol may be valid even more potent antiplatelet drug than clopidogrel, especially as an alternative strategy in treating patients with clopidogrel intolerance. We all know clopidogrel has very genetic cause of intolerance. Platelet aggregation, the minimum platelet aggregation is observed with ticagrelol compared to prasugrel and clopidogrel. Same thing that is depicted, prasugrel and versus ticagrelol tablet study. So what is data suggesting? That ticagrelol significantly reduced cardiovascular and all-cause mortality compared to clopidogrel. No statistically significant mortality reduction with prasugrel, clopidogrel, almost significant, similar. So compared to clopidogrel, both prasugrel and ticagrelol are definitely superior in patients with ACS, and there is no significant difference in prasugrel-ticagrelol outcomes. But very interestingly, COMPASS trial, we know that COMPASS trial, rivaroxaban and aspirin alone in another arm. And when it compared the results with the lipid lowering agent, BP lowering agents, and S inhibitors, what it says that there is in triple outcome and death and stroke, COMPASS rivaroxaban with aspirin is superior to lipid lowering BP and S inhibitor. So this is very interesting finding, and we should look at this angle in selected patients. If ticagrelol patient develops spontaneous bleeding, you can reverse the effect of ticagrelol, particularly if patient is going for surgery and you want to reverse the effect of ticagrelol. No need to wait for 3 to CABG, and you no need to, when you are already loaded before angio, and patient wants to go, patient has to go for CABG as per the severe disease, then you can reverse the effect of ticagrelol using this PB2452 drug, and very effective in using it. I think it is not available in India, may be available, I don't know. So what is evolving concept in terms of antithrombotic therapy? We have to divide this patient in 3 categories: stable, ACS, and high ischemic burden. So if patient is stable, 3 to 6 months DAPT, the bleeding risk is high, you can reduce to ultra short DAPT 1 month in stable patient. If precise DAPT score is more than 25, you can again use short duration, 3 to 6 months. If it is less than 25, you can use it for 12 months. Same for ACS. DAPT score, if less than 2 and more than 2, you can use, depending on that, a DAPT score. But in patients with high ischemic burden, we can try rivaroxaban with single antiplatelet agent, SAPT. It seems to be more sensible approach and should be considered because it reduces PAD, stroke, and the coronary artery disease. So in conclusion, short duration of DAPT as a routine therapy is absolutely no problem in patients with high bleeding risk. And it can be ultra short, 1 month. Current angle of aspirin-free therapy using only clopidogrel or P2Y12, one of the P2Y12 inhibitor drug seems a good approach, and aspirin monotherapy against clopidogrel monotherapy has been tried and seems to be safe and effective. In complex PCI, we have to go according to exact bleeding and balance the high ischemic burden against the bleeding risk and continue it for a longer time if you have ACS. Thank you for your kind attention.
Thank you, Dr. Vijayabang, for such a nice exposition of the advances in lipid therapy as well as antiplatelet therapy for secondary prevention of coronary artery disease. You have taken us through the whole gamut of lipid-lowering therapy, starting with the importance of non-HDL cholesterol, and then the additional categories of the Lipid Association of India, and the change in paradigm with the HDL cholesterol, and the effects of statins on plaque stabilization, calcification, and the importance of triple combination with the bempedoic acid, statin, and ezetimibe, and also the importance of lipoprotein A, and ending with the very, I think, wonderful future of gene editing, which has already started in New Zealand and this one. And they also covered very well the DAPT score and the high bleeding risk as well as the high ischemic risk in patients vis-a-vis the complex PCI and all. Thank you so much, sir, for covering the entire spectrum for secondary prevention of CAD. And to keep in proper perspective, I would like to say that we have not covered beta blockers and calcium AC inhibitors or ARBs in this lecture, because this was actually devoted only for statins and lipid-lowering therapies and antiplatelet agents. And of course, cardiac rehabilitation also has a very important role to play in secondary prevention, but that may be for some other talk in the CSI webinar series and that way. So over to you, Dr. Banerjee, for your comments.
Yes, Dr. Bang, very good disposition of the topic. So you have covered already most of the part of this topic. As said by Dr. Kavra, yes, there is a significant role of beta blocker and ACE inhibitor, particularly the patient with having the low ejection fraction, in the further improvement in the outcome in the secondary prevention. Now, my question to you, now besides these medicines or other parts, what you have discussed already, now what is your comment of using the digital health tools in the secondary prevention of the coronary heart disease? So because we know during the COVID time, we have extensively used these digital health tools, particularly on the mobile app and various other methods, so as to educate the patient and to teach them how to take the preventive measures and how to treat in such situation when he already sustained an acute attack of coronary syndrome. So what is your comment on using these digital health tools?
It's a very good question. We all know in India, in urban and rural area, urban and rural both, if we have a STEMI, patient doesn't understand it is STEMI. Start with that. Then he has to, if he understand, then he has to go to a close by center where ECG can be done and can be interpreted rightly.
Yeah.
because 10% of the thrombolysis is given in hyperkalemia.
Yeah.
So those patients are subjected to unnecessary risk of spontaneous bleeding. We know with thrombolysis, risk of spontaneous bleeding is very high. In our center, we take consent from the patient, written consent, before giving thrombolysis, that you can have a spontaneous bleeding in the brain and stroke. It's so important for all of us. Then third thing that is most important is digital tool. If patient has gone to a diagnostic center where technician is available, he has taken ECG, but he cannot interpret the ECG. You can use a tool to transfer the ECG to nearby ICCU, and you can transfer the patient for thrombolysis to begin with if cath lab capable center is not available close by. So maximum mortality, 65% of sudden death, sudden cardiac arrest out of hospital are due to acute MI. So if we only take care of acute MI through digital health, we'll be able to save lives and lives and lives. So in India, we have to develop first a proper STEMI network. So unless we have a STEMI network, we are not done. We are not done. As an association, we have a role to play there. And we want to do this, that we develop a STEMI network all over India, effective STEMI network. That is one. Second, adherence. For any primary or secondary prevention or rehab program, adherence is a big challenge. That's why I like inclisiran. Twice a year, just take a prick, and patient has to come. He cannot take orally. Patient has to come for a prick. So it's ensured that, okay, I can sleep now well, my patients are properly adhered to the therapy. Otherwise, I'm always under tension that I have done the PCI and my patient is taking DAPT or not, I don't know. If he gets admitted with another event or thrombotic event, post-stent, then he will blame me, doctor, angioplasty has failed. And it is called as failed angioplasty. So we have several challenges, particularly in our country. We have other challenges that the affordability, the insurance. There are several social barriers in management of the patient. And the most important barrier is patient doesn't recognize, he tells it is gas. And if you do a ECG and tell him that it's acute MI, he says, you change the machine now, I don't have a heart attack. I'm fine. So this is a major problem. We need a public education system to the digital mode.
Yeah, that's
and
important.
Responsibility lies on Cardiological Society of India to educate people. In 75th year, we have to do this job. Now educate public.
So you require more and more.
Because no matter how much academics we discuss, two of us sit down and discuss, if patients are not benefited, it has no value.
Yeah.
Community should be benefited.
I think with the passage of time, it will gradually increase the usefulness of the digital technology, particularly educate the patient as well as the public, so that they can take the measure. And as you have said rightly, that the ECG is done, but the reporting authorities, nobody is there at the time of crisis. So in that way, it will go a long run in future. And I think the India will also touch to improve this digital technology application for both the primary as well as the secondary prevention of the coronary heart disease.
I have to tell one anecdotal story. We have had our colleague practicing as a cardiologist in Mumbai who had his own proper heart setup, heart hospital. So he developed chest pain. He went to his own ICCU, took the ECG, and he himself read the ECG, acute MI, because no other doctor was available at that time. He himself read the ECG and told sister, give him thrombolysis. So she gave thrombolysis. He developed VT post
Post-thrombolytic.
post-reperfusion arrhythmia. He developed VT. Now he's not available to treat VT. He's gone in coma. He's not available to treat VT. He remained in vegetative state for 25 years. Recently he died. This episode occurred in 94.
So nobody was available to treat.
That is what, in city like Bombay, his own hospital.
Correct. Anyway, so we have a very nice discussion today. So now I request the sponsor to say the final word to conclude this beautiful session of the secondary prevention of the coronary heart disease. Sponsor, please.
Yeah.
Anybody?
Yeah, I'm here, doctor. So very good evening, everyone. My name is Preeti Mistry and I work as a General Manager, Sales and Marketing for the Corazon division of Alembic. As you know, Doctor, Alembic is a company which is touching lives of many patients over last 115 years. So at the outset, first of all, I would like to extend my sincere thanks to our honorable speaker, Dr. Vijay Bang, Dr. Nitin Kabra for the wonderful moderation, and Dr. P.S. Banerjee for this wonderful educational feast on the newer advances in the management of secondary prevention of cardiovascular disease using statin and DAPT. In fact, let me be very honest enough, Dr. Bang, your session was so insightful that I'm sure all of us who have logged in for this webinar would have been immensely benefited from it. Doctor, we as at Alembic would like to be in forefront in terms of disseminating the scientific information to the practicing doctors through such kind of webinars going forward also. And today for this webinar, we have a live relay. Your webinar has been relayed at 55 locations across the country. And put together, we have almost 200 doctors attending your webinar. And I'm sure all of them have immensely benefited with the new drugs, the new therapies which have been discussed by Dr. Bang. I also take this opportunity to thank all the participating doctors who had taken out time from their busy schedule, have come personally to attend the program at the physical location, and those who could not make it have logged in to attend the webinar which has been arranged by CSI. So thank you so much once again. And then last but not the least, we believe that your opinion matters a lot. So our team will be reaching out to the doctors who are attending this program in clinic to take their valuable feedback so that going forward, we can really make a good progress in terms of improvising. How do we enrich the entire program for the practicing physicians? So thank you once again and have a great day ahead. Thank you so much.
Preeti, just 1 minute.
Yes, sir.
Preeti, you are doing a recording of the program.
I'm not doing it. That's a CSI, sir. Yeah.
Whoever.
I'm not doing it.
You're not doing it.
No, sir, I'm not. It's a CSI.
You are just sponsoring. So
no, I'm just sponsoring it.
Technical support, please. Is there somebody from technical support?
Yes, sir. Yes, sir. Please.
So I want the recording of this program, please.
Sure, sir.
Make sure that you do it as early as possible.
Sure, sir. Tomorrow morning it will be.
Because unless this is disseminated, 200 is too low a number.
2,000, sir.
No, 2,000.
I said 2,000 doctors across the country.
Okay,
so there is 55 location where the program got relayed, sir. And we have online, the doctors who could not make it, they have logged in. So in total, 2,000 doctors have been immensely benefited from the content of today's program, sir. That's a good number.
So technical support, what is your good name?
Sir, Kishore, sir.
Kishore, can you reach out to me? My number is with you.
Yes, sir.
So kindly reach out to me and give me the recorded program.
Yes,
email me.
Yes, sir.
So thank you everybody, and have a good night. So we'll have a great session and good night to everybody. Thank you.
Thank you everybody. Thank you.
Thank you, sir. Thank you so much.
Thank you.